Welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PIcc Collaborative Community aims to harmonize approaches to speed delivery to patients through collaboration in the pre-competitive space. The PICC is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of the discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
All right. Welcome to the 12th and last steering committee of 2021 with the Pathology Innovation Collaborative Community. Thanks for everyone who made it today. I got a few messages that some people are stuck in meetings and come a little later, but I think we can still get started here. So, first of all, a big round of thank yous to everyone who has contributed. We made it through a full year of monthly steering committee meetings, and thanks for everyone who attended and contributed in so many things to this community. I think the first item, other than saying thank you and a big round of applause to everyone, is a synergy of several projects. And I wanted to briefly outline this because there have been several interesting developments. So on our website, you will find under projects the privacy pilot, which outlined a couple of privacy concerns, and you find a summary of the 21st Century Cures Act, which numerous people have contributed to. And one of those synergies was that some of the people, among those Joe Siren-Trappin, Laura Lassiter, several others, have converged into a new project that is called the National Tokenization Mechanism, or a Federated Identity Model. And there are a few elements that I wanted to briefly outline because they're really fundamental and have large-scale regulatory relevance. And the thank you. The link is in the chat already. I pull it up here quickly. So this is an outline on how unique patient identifiers may be used to clearly identify not only some medical record data, but unique individuals. There are definitely some concerns about another unique personal identifier, and revision of HIPAA is actually already happening. But what I wanted to briefly show here is a decision by the US House of Representatives happened on October 19th, and I'm not sure whether folks are aware of it, but the Appropriations Committee has removed a long-standing language that prohibited to use national funding from being used to develop programs for a national patient identifier program or initiative. So there's a link here on the website if you want to read this. That's a big deal because this has happened for multiple decades, but this has now been removed. That opens up the path for the Senate to, for example, solicit projects via the Department of Health and Human Services to approach a strategy at the national level for unique patient identifiers and the technology associated with that. So that is obviously extremely interesting, and there's tons of proposals basically waiting. Now, as part of this project, several of the people have put together a Iceboard, which is a national meeting in DC, I think in May. We put together an abstract identifying this unique patient identifier in a tokenization model as a possible way to start sort of putting a seed together. So Laura had the idea, and several people have contributed. Among those, Victor from WashU, Josie and Trappen from MSK, Ulla, myself, and several others. So if you want to read more, check out this sort of converged out of two different projects into a new project, National Tokenization Mechanism. And as soon as we hear back, this Iceboard session is proposed. If that happens, that has a lot of sort of regulatory implications, including, possibly writing this up as sort of a concept on how to identify individuals using, token technology. We were lucky to get one of the members, a long-term chief technology officer from Netcracker, which is one of the many telecommunication providers that acts globally to help with sort of a technology assessment of whether this will work or not. So that's sort of the first update, and I think it's meaningful. It will definitely apply to a lot of the healthcare and interoperability questions. I have in the meantime also reached out to Google. They have, with their Google Health team, an amazing set of resources of how to realize this. And there's a call in January about, whether this can or will work, or whether they will join this project as well. So I presume this will have a lot of traction, plus potential for funding. So whoever's interested can or should consider joining. As soon as we have a date for the next meeting, we will put that on the website, so just look out for that. Questions about this first item? I know Laura probably knows a lot more about the Iceboard meeting. Laura, can I call on you to mention what that meeting is? Because I'm not too familiar with it.
Yeah, sure. Hi everybody. So this is the international. I'm gonna slip up on the name, but the International Society for Dynamics and Outcomes Research, I think. So this organization, it's a lot of health outcomes researchers, as well as government officials, policy experts pay a lot of attention to this conference, as well as the publication that they put out, which is called Health Affairs. So in terms of a project that we're thinking about that could have implications on public policy, this is a great venue to get attention of, a government and policy maker. So it's pretty widely, attended, particularly for those groups, as well as drug manufacturers and payers as well. So it's just, and especially given that this will be held in DC next year, really great opportunity to get this out there to the relevant people. And just, so this is a panel presentation, which is really meant to have experts come and debate a particular topic. So excited, hopefully it'll get accepted, and it'll be just, I think, a really good venue to socialize this idea.
Yeah, no, it's fantastic. Thanks for the idea and pointing this out, and I hope that they will select this because I think it's a really meaningful project. There are no questions about this. We can probably move on to the next project. So there have been 3 sessions in a project called the Clear Waiver Project. It is not a clear waiver, hence this little asterisk. It's an enforcement discretion via a memorandum. And there's 3 full-hour sessions and discussions already available online in the respective project part. And as part of this initiative on basically extending some of the regulatory exceptions during the pandemic, we are currently drafting a letter that is probably going to be open on the website and also addressed to CMS to outline what regulatory changes should be maintained and what enforcement discretion has brought up and what we're thinking about. One idea that has been floated is to also request input from the state survey agency contacts. So every single state has a state surveyor. They have a lot of experience on what clear inspections look like and what could be the appropriate approach. And of course, we're gonna request additional input or contributions from other groups and interested parties. And this will follow the same format as with the federal notice a few months ago, where we put out a relatively comprehensive summary on the website that then people can use as a resource for their various policy activities. We won't engage in actual decision making or anything or in the political discussions, but what came out in these 3 sessions was that there's a lot of confusion of what the regulatory exceptions actually are, and that is already available as a resource, a PowerPoint, and all the relevant links to the relevant legislative sections in the federal code and pertinent other documents. So if you want to contribute, consider joining. The writing team is currently putting this together, so there should be an update on the website soon, which we will send out to the entire membership as sort of an update. And hopefully we can create sort of a good use case for this. And just to give you sort of a quick idea, the basic principle is, of course, previously you would have needed a clear license. The memorandum now says you can work without a clear license under 5 different points. And then the future state would either to make this permanent, revert back to normal, or propose a rewrite to set a new standard. And the approach that's kind of outlined in the memorandum was the basis for us now approaching the state surveyors as an additional group that is probably very knowledgeable about how to actually realize this. So I wanted to briefly throw this out there, and I don't know if there are comments. I know many of you have implemented digital pathology during the pandemic, so questions, suggestions? All right.
So the concept is for the group to try to develop a pathway to clear waiver for digital pathology tools.
Yeah, so the idea is that many people have stated that during the pandemic and the, let's say, slightly looser regulatory framework that was implemented during the public health emergency, that has enabled adoption of digital pathology.
Mm-hmm.
More so than previously, where every single, let's call it, home office or remote site required their own clear license. Now, of course, once the public health emergency ends, this memorandum would be not in effect anymore. So a lot of company, industry, vendors, pathologists have suggested, how can we make this permanent? A couple of papers have been published about it. The validation, the implementation papers from MSK are frequently cited. CAP has a validation guideline, and they already incorporated some of the the changes and what that would look like. But so far, to my knowledge, CMS is waiting for input, but there has not been a formal draft letter from the DPA, CAP, ASCP, but they all have reached out and asked, what does that actually look like? So the current state is basically unclear, other than that this memorandum clarifies that certain sections, to be specific, if you fulfill all the other rules, 5 rules have to be fulfilled, and these defer to various sections in the Federal Code and in the Public Health Service Act. That becomes very convoluted very quickly, but the memorandum is actually addressing not pathologists and not lab directors, but state surveyors, to basically say, if you identify a lab that has no clear license for a remote site, do not quote them as being non-compliant as long as they fulfill these 5 criteria. Now that's a very genius approach to basically not start changing the rules on the upfront legislative, but more on the survey part. And that could be the blueprint for changing this, permanently. So getting input from the state surveyors was the next logical step. And then, of course, at some point we would have to come up with what is the mandatory rule set. But there's a lot of additional information in these sets among many, many different things here. Let me just quickly pull this up just to keep things sort of in perspective. There's also a very convoluted approach because this memorandum affects everything in pathology, not just digital pathology. So if someone keys out a case or is, signing out or reviewing just lab information management flow cytometry reports remotely via VPN, that is also considered a remote activity. So we provided sort of a framework. Are we looking at just reviewing cases? Are we taking slides home? Are we, the memorandum encompasses all of it. So getting a little bit more input. Of course, we're focused highly on using digital pathology remotely, probably for primary diagnosis. But these sort of like different genres of pathology and remote work would likely have to be accounted for. So it's a relatively comprehensive 3-hour discussion. A lot of topics were touched upon, but I just wanted to provide sort of a quick outline of what this group is proposing. So there will be, of course, notes and a public statement with a disclaimer, of course, that this is not, anything regarding legislation, but more clarifying what possible approaches we can take. And then
fantastic. Thank you.
Similar. Oh, thank you.
Sorry.
No, similar as with the enforcement discretion or the federal notice project that we had a few months ago. Let me just pull this up real quick. Beautifully organized website, of course. Props to Ulla. So here's the disclaimer that the statement is not authorized by the FDA and that this is, a couple of individuals contributing. And at the time, for example, this was, the federal notice, we said some folks drafted, some folks contributed, and, so similar to this, we hope that we put something out there regarding this so-called CLIA waiver, although it's CLIA waiver is a specific term, so but everyone calls it that, so we stick to the jargon.
Thank you.
No, of course. Other questions about this? Hey, Joe. Thank you for joining.
Sorry, I was a little bit late. I had a consensus that ran quite a bit over. So
I hope you reached consensus.
Not really.
All right. So the next topic, which has been proposed before, and we have had a project before on the Valid Act that outlined a little bit of what the laboratory developed test versus in vitro diagnostic regulation may change. IVDR is, of course, the new framework in the European Union, and a lot of folks were interested in what does IVDR versus LDT look like. We received several emails about this. I just wanted to reiterate in case you're interested in this topic. What are you interested in? and please shoot an email to Ulla or myself, and then we can initiate this as an additional sort of project to just outline and further increase sort of understanding for the regulatory changes that happened on the European Union side, and that probably affect a lot of the LDTs and IVDs that are used in the US, especially when it comes to like globally supported or pharmacy supported trials or biomarker related studies. Good example is the Ki-67 quant that has recently been approved as a companion diagnostic, so there were several aspects here. Questions or suggestions about that? All right. Next is sort of a pointer to, I know Kim has been working on this diligently. It's also one of the projects regarding biomarkers and whether, you know, H&E based biomarkers can qualify and what that would look like, maybe for a Q submission. So this is the official project title, and at some point in the past there was a question about what the biomarker terminology, and that there was apparently some misunderstanding of some of the biomarkers. We just added this to that project site. This is a talk from Shashi Amour. This is like a FDA-based resource. This is an educational module series. There are many, but this is module 1. This differs also to several of the dictionaries and resources from the FDA about how biomarkers are defined and what terminology is used there. So I just thought I'd give a brief pointer to this. And I don't know, Kim, if you wanted to say a few things about the morphology-based biomarker status. Doesn't have to be a lot.
So yes, thank you. So right now we, as I talked about probably a couple of months ago, we were at a stage where we, since we did not have any actual hard data for some of the information that we wanted to put in an upcoming publication, we wanted to generate some data based on some of the TILs information that we're thinking about pushing out and moving forward. And to do that, we were going to develop we actually had developed a rough outline of a survey that would go out to professionals and a survey that would go out to patient advocates to get their perspective really on, you know, what is needed to really do justice to putting forth a biomarker that is morphology based. And we are at the stage now where the several us, Joe and Roberta Salgado and myself are reviewing that survey and comparing it with some survey that has recently been pushed out by the TILS working group, which I am also a part of, to just make sure that we do not have any overlap with what's there, and to see also if there's any learnings that we can take from that or just completed, literally recently completed survey that was done in November, to see if we can take any learnings from that and add those to our questions as well. So that's really where we are with that. I'll have a little bit more information for you in terms of where our next steps will be in January, because of some things that are going on in Europe. So yeah, so my apologies for not being silent on that, but we've just had a lot of things going on with that we couldn't disclose.
Oh, perfect. Thank you for providing the update and for sticking to it. It's a definite needed and very complicated project.
Very complex. That's a challenge.
It is. The next section here is just sort of a quick overview over, in this case, 4 or 5 noteworthy papers that I just thought it's a small but hopefully meaningful Christmas present for everyone. I think Ulla is pasting those, and I just thought I'd show you quickly why these are relevant. The first one here is from a group in Canada. Jean-Christophe Bellil-Pipon, I presume is the correct pronunciation. This is a very, very thoughtful systematic review of the literature on artificial intelligence and health technology assessments. Sounds like a very niche group, but it is how do you assess certain health technologies when it comes to AI? And they started with 366 studies and included 46 studies that they put in a certain framework that identifies whether there's an emphasis on, for example, increasing expectations or whether it's touching on legal or ethical points. We have a separate project on this. But this sort of outlining constraints or really enabling traditional health technologies, this is a very thoughtful, I think, approach on putting literature or papers into various frameworks. And what they came out with, sort of like what the systematic review enabled, is that you can really, once you put papers in these bins, you can say that what are the key considerations if you want to publish something in this particular realm of these 5 groups. Very, very thoughtful approach, and I thought I share this because if you write a paper that says, hey, here's what you should think about and what AI may enable, they kind of in this one table, in these 5 different groups, I think it's a must read if you're publishing something, especially if you want to polish up your discussion or if you want to update, let's say, on problems, etc. So this is the first part here. So what makes artificial intelligence exceptional in HTA, so in health technology assessments. The second paper, somewhat related to what we're working on in the payer group, is a very interesting study, in this case published in the JAMA journal. And this is related to payer strategies. Don't be alarmed, it says next-gen sequencing here. But assuming that there would be a national coverage determination, in this case for next-gen sequencing panels, this study looked at whether certain minorities by race and ethnicity would be benefiting from that. And the interesting solution, the study is very complicated. If you want to read it, I think Ulla pasted this already in the chat. But the result of this, a completely well-intended regulatory national coverage determination, resulted and demonstrated in this study that expanding a Medicare covered benefit program, not across all insurance types, may actually not occur equally across various patient cohorts. So this study, for example, demonstrates that, in African American and Hispanic Latino individuals, because not every single insurance type is affected by the national coverage determination, these rates of coverage may actually lead to disparities rather than enabling broad-scale use. Now, thinking about digital pathology and our approach to get paid for this, I think this is a landmark paper by methodology as well as their objective and how they stratified this. So I think if you're interested in reimbursement and strategies for national coverage determination, in this case with the Medicare program, this is a must read. And I forgot exactly when this came out, but it was, I think, yeah, December 9th. So this is hot off the press, and it's making some waves, as you presume you can imagine. This is nearly 100,000 patients in this study just to examine this. So very thoughtful study on racial and ethnic disparities among Medicare beneficiaries related to next-gen tumor sequencing. The next paper is a multi-omics machine learning predictor of breast cancer therapy response. I cut to the chase. This is a Nature paper, of course, with hundreds of pages of supplement. The data curation in this case, and this is the verification already, as you can see, is very tough to go through, but this is multi-omics, where they show an incremental increase in predicting complete response to therapy when you only use clinical data, DNA data, RNA data, DNA and RNA, RNA, DNA and digital pathology, and treatment data. So the number of correctly predicted cases as a surrogate here, the area under the curve on an ROC operating curve clearly demonstrates that digital pathology now at the nature, science research level has reached sort of a similar modular status that will be plugged into DNA, RNA, and digital pathology and leads to, at least some additional benefit. Not in every case, and, DNA and RNA seems to be higher, but, there's a lot of aspects in this paper. I wanted to briefly point out this is from a group in Cambridge and Australia, just to be complete. So Stephen John Samet from the group around Helena Earle and Carlos Caldas. So if you haven't seen this, this was accepted 23rd of November and came out 7th of December. If you missed it, this is definitely a fantastic read and validation in an independent set of 75 patients. So definitely another paper to look out for. It sets a definite standard on how to do multi-omics machine learning prediction, in this case in breast cancer, but just also how to think about portraying it. The next paper is Elemento, which is a review, or it's a viewpoint, in this case in Nature Reviews on cancer. And there's definitely a lot of hints regarding digital pathology in there, that it's, for example, if you just zoom in here, for example, training a digital diagnostic tool for digital pathology images of tumor samples is primarily an engineering problem. I don't know if we all agree with this, but I just wanted to point out that that's definitely happening at least the Nature Review level. And then Johan Lundin mentioned here, I think that was something that will likely be quoted: digitization will free pathology from the tyranny of physical slides. If you consider that tyranny or an enabler or, the fundamental basis of diagnosing cancer. But it's definitely an interesting quote. I think, if you hear this or want to quote it in your paper, here's definitely the group. So it's an interesting review, and this style of having contributors write individual sections may be something that we can also use, especially when you do point counterpoint or strong personal opinions. And I thought that was an interesting approach, where it's almost like a conversation where multiple people answer the same question differently. It's a very novel thing. I haven't seen this before, at least not in Nature Reviews on Cancer. So Elemento et al. Also like an interesting paper on, in this case here, AI in cancer diagnostics. The last paper here is more for the IT folks in the group. This is an interesting perspective from clinical oncology, also just came out. It's called Hidden in Plain Sight. Clinical informaticians are the oncology subspecialists you did not know you needed. So for everyone who is in oncology, so this is, I think, addressing some of the folks who are actually in oncology, seeing patients, trying to navigate, trial matching. And this is kind of a brief outline of what oncologist training looks like, and that clinical informatics and some of the alternative training options are outlined. And then again, same theme here, individual folks kind of outline their specific practice and perspective on whether they are or not sort of in dire need of clinical bioinformatics support. Thought of also very good perspective. And in the discussion point, I think if you want to read over some of these, follow your interests. No experience, however, seemingly unrelated, is a waste of time, when you try to figure out how to solve your data science problems by yourself. Find mentors in informatics, recognize that learning takes time, Don't know if you think that that's very thoughtful, but I thought it's definitely a very important point, especially when talking to our oncologists. And, the hidden in plain sight is a very good way of putting this. So, in other words here, I don't know, potpourri of noteworthy papers that came out towards the end of the year. Probably for these groups, amazing accomplishments, all of them for 2021. And so I just thought it would be great to to have those on your radar in case you haven't seen that. All right. Last item for today's sort of meeting is that we want to bring back some of the presentations. I think there's a lot of interesting topics. I think some of the health technologies that we heard about before, we're going to bring that back for 2022. Here are some of the outlooks for the first half of 2022. The publication on payer strategies is pending, cooking. The MDDT submission, I think Brandon can maybe report back in January on some details. We have already reached out to some additional patient advocacy groups. I have a meeting scheduled in January to have more patient representation in PIcc. And then we're still discussing whether we have at least a get-together. I don't know whether this will be a full in-person meeting, but there were some discussions about possible dates and or times. And I wanted to open that up for discussion here, what folk thinks about USCAP meeting in March, which will be in LA again. That's where we met 2 years ago, just as the pandemic started. Or, you know, another alternative is the CAP meeting in October. I think there will definitely be some PIcc gathering around the Visions meeting. That's kind of a given because of, you know, industry interests, etc. So we didn't include this, but for an annual meeting, the two meetings that came to mind that have a lot of pathologist representation would be, you know, the USCAP or the CAP meeting. And I just wanted to hear what folk thought about sort of an in-person meeting in 2022.
So you would definitely want it to be linked to another larger meeting versus a standalone meeting,
So
correct? Is that the
we
consensus?
we had previously discussed one meeting every other year at the FDA campus, but we don't know whether that will be possible due to, you know, the public health emergency restrictions. So if that is lifted, you know, that may be an option, and that would be possibility of a standalone meeting. We thought that, you know, if it's coupled with a data gathering event, which we have done before, I'm not sure whether that's possible, but having pathologists present is of course helpful for things like that. Plus, you know, spreading the message for those who do not know what PIcc is and why regulatory science is relevant. That was the idea, to couple it with another meeting. Plus, you know, people travel there, but it doesn't have to be. That's clear.
Hello, Joe. It's Brandon. I was a little late.
Hey, Brandon. Thank you for joining.
Meeting on my calendar got moved to next week, but I hope you guys know that. I sent you a little email about that. But regarding this question, I would say for me and FDA folks, this new surge is definitely messing up our return to campus, and definitely I haven't heard anything positive on travel that isn't, you know, related to shipping medicine and food around the world, mission critical type stuff. So I think March is too early for us.
Yeah, I think, you know, we can have, like, you know, a social get together and, you know, just send that out to folks who are at USCAP. It doesn't have to be like a formal meeting or data gathering. I think the data gathering related to or coupled with a CAP meeting in October, that sounds more realistic. That would be great. I don't think we have met anywhere near or associated with a CAP meeting, but I know there's the House of Delegates, there's the, you know, trainee section of CAP. So there's a lot of, you know, elements. I don't know about the ASCP meeting. I don't know, Joe, if you know when that is or where that is.
I think that, well, they haven't planned it yet. They might already have the date scheduled, but I know for the planning, they haven't started in terms of, you know, the venue and what it looks like. So it's still preliminary. They're going to work on it probably in January.
Got it.
Any meetings in Hawaii?
We'll probably be shut out, isolated, right? They have a quarantine or
Jet ski, Victor.
Yes. Thanks.
We need to meet on jet skis. So maybe I see a soft trend towards later in the year. Is that a fair assessment? So like maybe something like a social gathering.
would API work? I mean, we're still up in flux about, I mean, we're hoping things die down. March is early, but May, it's possible.
API is in May?
Yes, it's in May. Let me find it.
Pittsburgh or?
Pittsburgh, yeah. Let's see if I can find it. Here we go. Oh, shoot. I would say API Petroleum Summit. No, that's not what you want.
I'm sure there's some regulatory constraints on that industry.
No regs.
I put the link in the chat. It's May 9th through the 12th.
Thanks.
That sounds like an earlier possibility than October, so that may be a good idea. Plus, a lot of people at API are interested in digital paths,
Yeah.
so no, that's great.
You know, they're actually calling for proposals too, so I don't know if it could be officially put in there. I don't think the deadline is. They keep extending it, so that's also a potential. Let me look.
No, that would be great. A little more outreach and.
I think we just finished reviewing all of the sessions.
Oh, you did? Sorry about that. Well, actually, it says January 31st. Is that right? Let me put this in there. Maybe I misread something. I could check with Nova too. But that looks like the deadline's January 31st.
Reactivate it. Yeah, so I thought at the CIP meeting, the residence forum would be a good venue to outline the trainees group. I think most residents may not yet be interested in regulatory science, but at least making sure that those who are captured, and or the various delegates from the various training programs disseminate that information. I think the residence forum may be a good way to disseminate that information. And we can definitely talk to our delegates from MGH and or Brigham, and maybe, I don't know if MSK has some fellow delegates, or some of the other training programs. Stephen, don't know if you have some at Mayo, but then, or Victor at WashU. If the residents presented, or if some of our trainees present, that would, spreading the word.
For the record, Joe, I was just going to say, for the record, that API conference, the organizers have been pretty generous with me previously on the Sunday before the conference actually starts, offering a room and space. just so you know that usually is an easy one for them to offer. And I think we have a few people here that can put in a good word.
Yeah.
Yeah, I think the, actual data gathering event makes it a lot more practical than just talking about it in theory. And I think, at the meeting at USCAP, when the pathologists who walked by were able to interact and talk also with you, Brandon, and your team, right, Sarah, etc. That's very helpful to really think about what's needed to obtain high quality data.
Yeah, we do have a proposal in for a session for the HTT project already, and to run data collection there though, everybody seems to be a presenter in that conference, and not a lot of just pathologists walking the hallways looking for interesting things. It's pretty intense and focused and busy, it seems. But that's my impression, that there might not be a real population of pathologists to do much. And if they are, they'll all be free at the same time and busy at the same time, which doesn't kind of lend itself nicely to data collection. But
Yeah,
CAP,
Yeah.
I was just to say CAP, I think they're pretty familiar with the project, and Mary Kennedy has kind of promised without promising opportunities at CAP to do some data collection. Unfortunately, it never has lined up, and there's been a pandemic for 2 years, so that's kind of screwed us in that area. But I think that would be my choice. And then ASCP, we've actually done data collection, and they've been very generous as well, getting us a spot next to the coffee and donut station, and we paid some nominal money for some of the equipment, and they stood up some walls and things and curtains for us. And
Talk about prime real estate, location.
Oh yeah. We definitely thought that was quite successful at staying busy and at least getting eyeballs on the project, things like that.
So it sounds like several opportunities, and at the mercy of COVID we are. No, I think it would be great to couple, our efforts with some of the more practical things. If we do a meeting like this, I think, Kim, for the survey, about biomarkers, that would be a thing to put a laptop there and have, pathologists just walk up, fill it out. That would be an additional way to get people's opinions captured.
That would be awesome. And that's what I was actually just thinking about that as well as you were going through the laundry list of possibilities. I'm like, wow, there's a really great gathering opportunities.
So I know the USCAP meeting, I think, starts on Saturday. There's a morning course. And I think I know that the CAP Residence Forum, as well as the delegates, meet typically on the Saturday before the USCAP meeting. And then the societies usually meet on Saturday, if I'm correctly informed. So that may be another option, to have like a meeting there in the morning, and just for those interested. And I'm sure we can spread the word through the USCAP newsletter. Just to say, if someone's interested, we can have like a meeting somewhere there.
So how many of these venues actually have patient advocates at them? It's been a little while since I've done USCAP, because that's the one I would usually attend. But
I know CAP is working closely. PIcc and some of their sections have strong ties to patient advocacy groups. I know ASCP has as well.
awesome.
I'm not sure about API, so maybe we could include that in our proposal.
Yeah, I don't think so. This is regulatory science hasn't been a big part of it.
Okay.
And use cap, I'm not sure. I know that some patients have been invited for some of the talks to report their personal journey, but I'm not sure whether like formal patient advocacy has been on the, like, you know, key items. I mean, it's mostly, I would call it AP heavy, diagnostic focused, and academically interesting. So.
Right. So that's been my experience in the past, but I haven't been in the, you know, last couple of years. So didn't know how much things have changed. That's fantastic.
Perfect. Other topics, suggestions?
Looks like we have a new member. Fantastic. Get them as young as you can.
Yep, the family time just keeps getting better and better and more extended and longer. And we're all on vacation now, or at least from school. You see he's got a unicorn for you, Everett. He would probably slash that with his dragon blood warrior that he has.
Huh?
Well, then I have to bring out the tiger.
Dragonborn.
All right.
Seems like Joe has an entire zoo in his office.
Yeah.
Everyone is avoiding the COVID because right now everybody I know seems to have someone close by, and we had our own exposure in the house. So we're under isolation and quarantine just in time to have to change all of our holiday plans.
Oh.
But at least we're warm.
Yeah.
And employed.
And working on interesting things.
I have more time to work now that we're not going anywhere. Isn't that great?
Always recommend quarantining in Hawaii.
There you go.
I leave for Hawaii in 8 days.
Uh-oh.
Conference.
Yay.
So I see that place is not just on accident being mentioned here.
Yeah, I'll take those trips when I can get them.
So I definitely wish everyone a happy and safe Christmas. All the other holidays that I always seem to forget. But in the new year, I hope everyone is safe and happy and eats a lot of good food.
Same.
Yeah.
Joe, I don't know
Right.
if anybody tells you this, but I mean, somebody should just say thank you to you because you of all the work you put into this group and how far it's come. And you know, I don't know if